And if I was really courageous, I would try to figure out how to split it on two as opposed to three monitors, but I don't think I will, since you guys came to see a PowerPoint presentation and, in a sense, a discussion about what you've been negotiating the last few months, ever since we went open. The whole nature of this particular presentation is to give you at least some insight as to what's occurring, why, and where's it going. We've put this presentation on in regions 3, 4, 1, and 2. So today, in the morning, you're seeing it. I'm going to take it over to Pocatello, and then I'm going to go over to Twin Falls tomorrow morning. And it's the hope that it's the beginning of some dialogue between Optum, the Department of Health and Welfare, Medicaid, and you people as providers. That dialogue is going to become very important in the context of viability, survivability, and effectiveness in terms of what we want to be able to do. So anyway, by way of absent introduction, Dr. Jeffrey Berlant is our Chief Medical Officer. He's a longtime psychiatrist in Boise over the last 25 years. Has some extensive experience with care management. My name is Dennis Woody. I have been a pediatric neuropsychologist in the Boise area for the last 22 years, consulting with the state of Idaho for about 20 years, the school districts in Boise, and also a hospital-based practice and a private practice. So I've had the opportunity to be around Idaho. Actually, I'm originally from Emmett. Finished my undergraduate work at the University of Idaho. Any vandals out there? Very good. Very few of them. Okay. It's tough living in Boise as a vandal nowadays. In this presentation, and there are about 24 different slides that I'd like to take you across. We're going to discuss these high points of the program that Optum is unfolding. After I've done that, then we're going to take a break. And what I'd like you to do is to write your questions down on a card. Aaron, I didn't introduce Aaron. Aaron's my colleague from Boise. He's the community liaison, or one of the community liaisons for Optum. Anyway, write your question down during the break. Now, when Dr. Berlant and I did it in regions 3 and 4, we alternated in answering the questions. There are about, how many, what did we figure, 100 folks here today, Aaron? Okay. If you each have a question, it's likely I won't get to all of them, because I do have to kind of leave here by 11:15 or 11:30. But it'll be my genuine attempt to answer as many of them as I can. So if you write down your questions during the break, I'll try to assimilate them into similar categories and deal with them as best I can. If you don't get the answer that you want, or I'm not clear enough, or I have an I don't know response, we'll try to get you that answer. It's not like it's a dead end. Just by way of query, how many of you here have called to talk to customer relations or customer service? Okay, so maybe 10, 15. One of the things you're going to hear repeated over and over again is that this is a dialogue, an interaction. And I know Optum didn't start off on the right foot technologically. Hopefully, you've encountered fewer difficulties with the phone and the care manager's contact. That was a very difficult circumstance, not only for us, but I'm sure for you, waiting online or waiting on the phone line. Anyway, today in this presentation, we're going to talk about some of Idaho's unique aspects. What is it here in Idaho that we have that's different? Why is it that we're doing what Optum is doing. We're going to talk about the benefit structure as well. There is a term that I've heard, at least in the last two presentations that I've done. Medical necessity is something that I think there's not a lot of clarity in the provider domain. So we'll talk about that.
Your microphone keeps going in and out.
Does it?
It's really hard to hear.
You want me to put it on like the jet fighter pilot? So we have another one that was a stick mic, but maybe this will be better. There are two case studies in this slide presentation. I may skip over those case studies. It kind of depends on how our time is running. If I do, then these case studies, along with all of these slides, will be on the Optum website, accessible to you when we're all done giving. I also want to provide you with at least some preliminary instructions for how to negotiate this process. This system transformation that's occurring is not unlike what's happening all around the country. There are some unique elements in Idaho, but they're negotiable, or at least we'll be able to get over them. And then ultimately the summary, and then we'll wrap it up. As I mentioned to you earlier, this change in Idaho is a reflection of issues that have been occurring in the United States for the last 10 years. People want to know where their money's going. They want to know why people aren't getting better. They want to know how best to get those people better. And so as a consequence of that, accountability, reform, uniformity is becoming more and more and more the watchword around the country, not just in mental health and behavioral health, but in medical practices in general. And if you followed any of the stuff, for those of you who work in hospitals, you know what I'm talking about. People want results-based outcomes. They want to know incrementally and in a measurable way, how am I going to get better if I see you? What is it you bring to my care that makes you unique from the guy down the street? So that sort of thing, in terms of measurability, becomes a very important question when you have publicly funded resources that are going to people who genuinely need the care. And as a consequence, you have situations like we had in Idaho over the last 4 to 5 years, where people were really wondering, why is this thing escalating like it is for the Medicaid dollar expenditure? So eventually, the legislature, hearing from the constituents, made the determination, we need to do something differently. We need to figure out how to do this in a way that's going to use our resources well and get the care that we want to go to the folks who need it. For those of you who've been in Idaho for a while, particularly those of you who have been observing some of the allocation of the resources, you've heard the criticisms, particularly for things like case management and CBRS, or PSR. You have heard the criticism. Not that all of it is appropriate, but the criticism was there and the legislature heard it. So Optum, along with several other nationally oriented companies, bid on the contract, and Optum was awarded the contract. So that's why Optum's here in Idaho. It's at the behest of the legislature, with the support of the Department of Health and Welfare, trying to figure out how are we going to use this precious amount of limited resource to get to some folks who really need the care. In the benefit structure that Optum has brought, most of you who are providers, just by way of interest to me, how many of you here are actual providers? How many of you here are owners? Any other groups here? What are you representing, sir?
National Alliance on Mental Illness.
I see, very good. And did I see another hand over here?
Yeah, I'm an intern for the Master's Social Work program at NMU.
Okay, great. For many, many years in Idaho, we had a very colloquial system that was relatively small and could be small because we didn't have a lot of people in our state. We were geographically dispersed, and it was evolving in a way that as our population grew, the way of managing and looking at how the resources were used became more difficult. Folks who were in the public provision domain actually weren't monitored. There were certain caveats that if you went past a certain level or threshold, you could be investigated, you could be audited, but there really wasn't a consistent collaborative way for you to communicate with the system that was providing you with the resources that you needed to treat the folks that you wanted to see. And so as a consequence, you ended up in this situation where you were trying to do the best you could with what you had, but sometimes the clarity of what was being told to you wasn't ideal. And so it put you in somewhat of a tenuous position. You could do something that maybe the directions didn't exactly say you could for the benefit of the patient or the member, but you were never really sure if that might jump up and bite you. And so this position of directive and execution unfolded over 10, 15, 20 years. It wasn't until the concerns about where is all this money going, and the legislature got involved, that the impetus for change came about. In the prior Medicaid program, you had caps. Couldn't use X amount more than this annually. You were also told that you couldn't do duplication of services. Like, for example, if you were doing individual therapy, you couldn't do family therapy, otherwise it would count against what you were using for individual therapy. As Optum came in and looked at that, it seemed to make more sense to begin what Optum has done in other areas of the country. There isn't a benefit, or excuse me, there isn't a limitation on the benefit in that sense. We don't have caps. So in other words, if the person that you're seeing, you genuinely and clinically can demonstrate they need to be seen twice a week, they need to be seen in family therapy and individual therapy simultaneously. If you can genuinely justify that, we want you to do it. But in the same vein, we're going to ask you questions clinically about what you're seeing. That's the issue of care management and collaboration, which is why you've been compelled to talk to care managers. Some of you have elected to go to peer review and talk to me or Dr. Berlant. That is what care management is about for the most part. There's more to it, and we'll talk about that. This slide is a depiction of how Idaho Optum is laid out. And I want you to take a look at it while I'm going to drink and appreciate the difference between that and the Medicaid plan. All of those have no caps. It doesn't mean there won't be questions, but they have no caps, folks. If you feel that the child and the family that you're seeing would be better seen in their home because that's where the problem occurs and that's where the child is going to learn best, we want you to take that off site and go do it in the home. Now, are you going to, well, I was was asked several times, well, how are we going to pay for that? Well, the truth is, the fee schedule is what it was when Optum came to town. It is the Medicaid fee schedule, and it does not cover your transportation. But if you believe clinically that the child and the family need to be treated more effectively in the home, there's no delineation on that CPT code that says you can't. However, in the old Medicaid plan, you couldn't leave your office. It was a clinic-based model. In the context of elements such as telepsychiatry, there are moves afoot beyond the MD and the psych neuro, or the psychiatry nurse practitioner, to make available to the folks who live in our state counseling capacity that's telephonic, not telephonic, but over a secure video connection. That is not Skype, by the way. It is a secure video connection that's approved through HIPAA. That's not legal for you to do now, at least in terms of serving people who are under a Medicaid coverage policy. But eventually, the way things seem to be moving, I think you can anticipate that there are going to be more than just MDs and prescribers under that cover. And for those of you who are involved in CVRS under the Optum plan, there will always be a role for CVRS. It is a very different role than what it was in Medicaid. We see it as being a clinical extension of what should be determined in a clinical model under a therapeutic guidance of at least a master's level clinician. So, CVRS will always be here. Partial care will be here as well, which is essentially CVRS in groups. Anybody here work under that sort of context? One person. Two. Peer support, or peer and family support, is a new issue, at least for Idaho, that we're hoping to be able to roll out by the end of February, or the beginning to middle part of March. The clarity on what that's exactly going to look like many things, is not certain yet, and adjustments and changes undoubtedly will be made. The feedback we get from you folks will help that occur. And I mean that sincerely. That feedback you give us really is important, because we know we don't operate with action. These are a few examples of some of the benefits billing rules. They are different than what you might be familiar with in Medicaid. And I actually had someone tell me in another presentation that item number 2, they tried that and it bounced back through claims. But then I also had half a dozen people raise their hand and say, but I've done it and it worked. If you see a family from Cary, Idaho, who makes the drive in, and they only want to be able to have to do it once a week, does it make sense to not see them as a family when in fact they need family therapy and individual therapy? It doesn't make that much sense. So what we want you to be able to do is to do what needs to be done. You can't do multiple of the same CPT code. If you do individual therapy on Wednesday, you can't bill again for the same individual therapy unless it's a crisis. That's a little different. The only caveat to that list of billing rules is that you can't bill psychotherapy on the same day you do the CDA. You've got to do the CDA first. And it makes sense in a clinical context because you don't know what you're doing therapy for until you've done your diagnostic interview. The hope in this strategy for transformation is that you're going to be able to deliver medically necessary treatment in whatever context is necessary to the members that we have. The bottom line that you will hear if you've done a peer-to-peer review, how many of you here have done a peer review where you had to talk to a doctoral level individual, not a care manager? None of you? Oh, okay. What you often hear in a peer review is a question from a guy like me is, what's the diagnosis? It's kind of a good starting place. Particularly when I get a synopsis that has symptoms that are not the diagnosis that I'm looking at. And so the question then becomes one of, who made the diagnosis? When was it made in the context of the treatment that you're offering? In other words, did you get the diagnosis when you first came into care and it kind of stuck with you all through care? Because these symptoms don't look like this diagnosis. So one of the things you're going to hear from us is it possible that that diagnosis has changed? And if in fact it is, what we want you folks to feel very comfortable doing is getting a second opinion. If you need to refer someone out for a psychopharmacology consult, if you need to have them go see a psychologist to do some psychological testing, we want you to do that, principally because it's good for our member. The reality is, if you're treating something that's been updated because you have psych testing and you've got a psychiatrist saying, well, in addition to that adjustment disorder, you've got somebody here with a cyclothymic or a bipolar disorder. That sort of updated treatment means that our member is going to be getting a more directive, refined sort of intervention. And hopefully they're going to get better sooner. The other issue is, once we've got the diagnosis right, we want you to be using evidence-based practices. And I know that most of you who have graduated from your professional training within the last 10 years have heard about what EBD is, or evidence-based practice. It is basically the summation of years of research in terms of specific interventions for a given diagnosis using specific treatments. The reality is, folks who have the evidence-based practice approach, they get better faster. It's cost-effective, and it enables you to use your talents for somebody else who's waiting in line sooner. That puts the onus on the folks delivering the service. Well, what's an evidence-based practice? And that's a genuinely good question. An evidence-based practice is one that we know empirically works with most folks with this disorder or this diagnosis. If you've had a chance to look on the Optum website, what you will find is a list of evidence-based practices for given diagnostic categories. Now, does that mean that no other therapy will work in any other circumstance other than this one that we've written down? The answer to that is no. But if you're using something that is outdated, if you're using something that doesn't have an awful lot of empirical support for it, it's going to be a good idea for you to first document. Why are you using that treatment? Because when the auditors come through, they'll be looking for the diagnosis and the treatment protocol that you're using. And they're clinicians, and they're very familiar with evidence-based practice. So they'll ask you the question. If you end up in a peer review or discussing with one of the regional care managers why you decided to use that, it is an interaction, guys. It's not a police state. What they want to understand is, why are you doing that? Is there a good reason for that? Are there alternatives to that? In my conversations with clinicians, it really does become a peer-to-peer consultation, trying to come up with different ideas about what could alternatively help this person. The other issue, and it is probably the most important and shouldn't be at the very bottom, is how are you measuring change? What is it that you used as your guide on? Where did you start? What was the incident of that symptom presentation when you first started seeing that patient? Because 3 years down the road, I'm understandably going to have some questions in terms of care management as to why are you still working with an adjustment disorder? What are the symptoms? What were you measuring? How has it changed? Which really does invite us into a conversation about treatment and evidence-based practice. In this model, what we've tried to state and then reiterate is we really see the members as coming first. What the member needs is preeminent over what you can provide. And that's a sticky wicket, because what if what the member needs is not what you provide? That's the hardest situation in the world, because then you're in a situation where you have to consider referring the patient or gaining some more knowledge about what that patient might need best. And it's not to say that you couldn't be the clinician. You certainly could be. We all grow as clinicians and expand our repertoires. But what that patient needs, or the member needs, is preeminent. We want you to do what we know works. And believe it or not, and I don't think you ever had this statement from Medicaid, if you're not sure, it's perfectly appropriate to call us now that we